Hi everyone, this is Haley and Bethany here, and we're here to talk to you about multiparity in pregnancy and delivery. Here are some objectives for you to review. And we'll just start with some definitions. So parity refers to previous pregnancies of at least 20 weeks gestation and is the P component of the GP abbreviation that we use in clinical practice. For example, a pregnant woman who is G2P1, meaning gravida 2, para 1, is pregnant for the second time and her first pregnancy resulted in delivery after 20 weeks gestation. Nulliparity refers to a woman who has never given birth or who has never completed a pregnancy beyond 20 weeks. Multiparity, which is what we'll be talking about today, refers to a woman who has experienced one or more pregnancies with delivery after 20 weeks gestation. So in general, there are multiple benefits to our patients that are multiparous. Studies have shown that in general, they will have shorter durations of labor with faster cervical dilation per hour, less dystocic labor, lower cesarean delivery rates, lower perinatal mortality rates, faster physiologic adaptations because of a more primed uterus, and less overall anxiety regarding pregnancy and the birthing process. So here you can see the labor curve that is shown in our apex. And that helps us determine what a normal progression of labor is. Through a multitude of landmark studies, Emanuel Friedman developed a framework we still use today, and this is known as the Friedman curve, and it displays cervical dilation on the y-axis and elapsed time on the x-axis. Friedman considered nulliparous and multiparous patients separately in this research process because of the physiological variances in pregnancy and labor for these patient populations. One possible limitation with this study is the fact that the initiation of labor is self-reported by the patient. The uterus contracts throughout gestation, and the perception of true labor can be variable. So therefore, the difficulty in determining the exact timelines occurred not with the transition between latent and active, but with the initiation of the latent phase. Many times, the parturian and the physician are not exactly sure as to when the labor started. The first stage of labor starts with the beginning of regular contractions and ends with full cervical dilation. This stage is subdivided into the latent phase and the active phase. The latent phase, which is also known as the preparatory phase, it involves cervical effacement and softening. The active or dilation phase involves regular increases in cervical dilation. The second stage of labor is considered full cervical dilation, which is 10 centimeters, to delivery of the fetus, and the third stage of labor is considered the time from delivery of the fetus to delivery of the placenta. As Dr. Todd mentioned, our chestnut text also discusses a fourth stage of labor, which includes the first hour after placental delivery. And here it's important to note that there's a high risk for hemorrhage and the patient should be monitored closely. In clinical practice, parity serves as an important determinant of labor length. Many studies have proven shorter durations of labor in multiparous patients. This highlights the need for caution in these women undergoing augmentation of labor. Nulliparous and multiparous parturients progress at similar rates during the latent phase of the first stage of labor. However, it accelerates much faster in the active phase in the first stage of labor in multiparous patients compared to nulliparous patients. Here we compare labor patterns in nulliparous and parous patients. In the nulliparous parturients, the latent phase can last up to 20 hours. The cervix should dilate at a rate of at least 1.2 centimeters per hour. This patient population shows lower cumulative labor rates overall. However, these differences seen between nulliparous and multiparous patients are more significant after 6 centimeters dilation. Before 6 centimeters of cervical dilation, the times required to dilate 1 centimeter are similar between nulliparous and parous patients. Within the second stage of labor for nulliparous patients, prolonged labor without an epidural is considered to be greater than 3 hours, and with an epidural is considered to be greater than 4 hours. For parous patients, the limit of the latent phase of labor was 14 hours. The cervix should dilate at a rate of at least 1.5 centimeters per hour. Within the second stage of labor for parous patients, prolonged labor without an epidural is considered to be greater than 2 hours, and with an epidural is considered to be greater than 3 hours. These numbers are significant because they help us determine if a patient's labor is progressing normally or not. They help us determine when labor interventions and assistance might be necessary to keep mom and baby safe. If a woman's cervix fails to dilate at the appropriate rate during the active phase of labor, this is considered primary dysfunctional labor. Here I've attached a chart from our Chestnut text, and it shows the results of a retrospective study. It displays the rates of spontaneous cervical dilation in nulliparous and parous parturients within the first and second stages of labor. It's evident here that the median cervical dilation time in hours is slightly less during the first stage of labor, but significantly less during the second stage of labor. A retrospective study performed in Israel that was examining approximately 44,000 patients indicated the differences in labor patterns and rates in the nulliparous and multiparous women. About half of these patients were nulliparous and the remaining were multiparous. The median and 95th percentile durations of the first stage of labor for nulliparous patients were 405 and 750 minutes, whereas they were 238 and 750 minutes for multiparous patients. It was also indicated that the patients presenting for admission with cervical dilation less than 4 centimeters, the time to get to the second stage of labor was 120 to 140 minutes longer in the nulliparous population. However, it was indicated that this gap between the groups dramatically increased when the dilation upon admission was larger. The median and 95th percentile rates of the second stage of labor for nulliparous patients with epidurals were 103 and 224 minutes, and without epidurals were 34 and 173 minutes. So why do we see these variances in labor rates? Here I've attached a study that was performed in Galway, Ireland to determine the differences in uterine contractility at term between primiparous parturients with one previous delivery and parturients with more than one previous delivery. Essentially, they took biopsies of these patients' myometrium during cesarean deliveries at term at this hospital in Ireland. They were utilized to measure maximal amplitude, mean contractile force, time to maximal amplitude, maximum rate of rise, frequency, and occurrence of contractions. Overall, the study results showed that the mean contractile force was greater in parous women, and they had a slower rate of rise and slower rate of relaxation. This definitely correlates with the common clinical view that parous women have more efficient and faster labors. So how does parity influence perinatal mortality? In general, multiparous women typically demonstrate faster physiologic pregnancy adaptations and deliver infants with higher birth weights compared to nulliparous women. It is suggested that multiparous women have a more favorable primed uterine environment after a first pregnancy. This study that I've listed here was conducted to determine if this leads to a decrease in perinatal mortality in multiparous women compared to nulliparous. Out of all total deliveries included in this sample size over the course of 4 years in California, approximately 60% were nulliparous and 40% were multiparous, with only one prior birth. This study concluded that perinatal mortality is significantly higher in nulliparous women with term deliveries. Nulliparous patients demonstrated increased rate of intrauterine fetal death, small for gestation age infants, and less than 10% birth weight, and more APGAR scores higher than 7 at the 5-minute mark. Here I've listed the percentages for nulliparous and multiparous patients within the parentheses. These study results are significant and may indicate an increased need for more surveillance on maternal health to maximize physiologic adaptation in the nulliparous patient population. Here I've included some subcategories of multiparity, which include grand and great-grand multiparity. Grand multiparity is a woman who has had 5 or more births, including live or stillborn, at 20 or more weeks gestation, and great-grand multiparity is a woman who has had 10 or more births at 20 or more weeks of gestation.
Okay, so we also looked at a study that was a retrospective study performed at an urban hospital in Taiwan between January 2001 and December 2013. And this was to look at the effects of epidural use both in nulliparous and multiparous women and to kind of compare the differences there. So trained personnel looked over the EMRs of deliveries every day, and they conducted personal interviews as needed. All deliveries were after 37 weeks of gestation, and they looked at a total of 23,018 deliveries. Pregnancies complicated by multiple gestations, fetal chromosomal or structural anomalies, fetal demise were all excluded. Women with a C-section delivery without a trial of labor were also excluded. This included a fetal malpresentation, placenta previa, cephalopelvic disproportion, a history of previous C-section delivery, previous hysterotomy for uterine fibroids, active genital herpes or condylomatous infection, a medical condition that would require C-section delivery or preclude epidural placement at all, or just by maternal request. So while perhaps not ideal, a blind clinical trial is just about impossible to conduct in this scenario due to the ethical concerns present. These are some of the factors the researchers knew could skew their data, but they were not accounted for in the study design due to a perceived lack of significance. And those are low pre-pregnancy BMIs, genetic amniocentesis, group beta strep of the genital rectal tract, and augmentation or induction of labor. So for both nulliparous and multiparous women, epidurals were performed at higher rates in patients with maternal age greater than 34 years, a pre-pregnancy BMI less than 19.8, a history of genetic amniocentesis, and GBS of the genital rectal tract. Recall from our slide before that these were some of our independent variables we knew could skew our data. So some of the standard protocol for this study. The epidurals were offered to all parturients regardless of their cervical dilation if there was no contraindication present. The standard protocol was 10 cc's loading dose of ropivacaine in combination with fentanyl and a continuous maintenance dose of ropivacaine combined with fentanyl at a rate of 10 mL per hour after the various standard recordings. And you can read the dosages on the slide. And some of those standard recordings were EKGs, blood pressures, and fetal heart rates. Those had to stay normal for 20 minutes. And then an additional 10 cc's of the drug could be administered for breakthrough pain per the lady's request. These epidurals were continued through the second stage of labor. So some of the outcomes we looked at were modes of delivery. C-section rates, operative and spontaneous vaginal deliveries were differentiated between. So a birth without any operative or instrumental assistance was categorized as spontaneous, and augmentation, episiotomy, or both were still classified as spontaneous deliveries. Associations between epidural analgesia and adverse perinatal outcomes were also investigated. Admission to the NICU, 1-minute and 5-minute APGAR scores less than 7, placental abruption, acute chorioamnionitis, severe perineal injury, which was defined as 3rd and 4th degree perineal injuries, and postpartum hemorrhage, which as we know is greater than 500 cc's for a vaginal delivery and greater than a liter for C-section delivery. They also looked at neonatal death, which is classified as death within 28 days after birth. So some of the nulliparous outcomes, they were significant risk factors for operative vaginal delivery with nulliparous women. It was also proved that in nulliparous women that epidurals could be protective against cesarean deliveries, but they did have an increased incidence of APGAR scores less than 7 at the 1-minute mark. APGAR scores were no different at 5 minutes between the groups, and no poor outcomes or effects were noted. The initial 1-minute difference was most likely related to an increased rate of operative vaginal delivery by vacuum extraction in this nulliparous group. Nulliparous women are usually more anxious regarding labor and delivery compared with multiparous women. They have no prior experience with epidural analgesia much of the time, and they're the main population that requests this type of analgesia. So in multiparous women, we found a significant risk factor for operative vaginal deliveries after epidurals. They were not shown to significantly impact their cesarean delivery rates, and they weren't shown to significantly impact APGAR scores at all. In the multiparous women, though, higher rates of gestational diabetes mellitus were noted in the women who did request epidurals. So that could play a slight role in the fact that these patients oftentimes had diabetes. C-section delivery rates, as we just said, were not significantly different between the women who were or were not administered epidural analgesia in this multiparous cohort. However, the frequency of dysfunctional labor as an indication for C-section delivery was increased in the women who were administered epidural analgesia, and that had a p-score of 0.005. So that kind of further clarifies that first little bullet point there. So overall, epidurals were shown in the study to lack any correlation with increased incidence of adverse maternal or fetal outcomes, and they were even protective against unplanned cesarean incidents among nulliparous parturients. Obstetric care providers would benefit from this information because this will enhance our counseling regarding the intrapartum use of epidural analgesia for our nulliparous patients. Thanks, guys. Let us know if you have any questions. And this is our reference slide.